Hi, this is a hip preservation webinar. Welcome to the webinar called I have a labral tear in my hip. What does that mean? I am Dr. Ernest Sink, who will be a host for the webinar. I'm the chief of the hip preservation service at HSS and manage pediatric and young adult hip disorders. The hip preservation service is a multidisciplinary service composed of physicians from pediatrics, trauma, arthroplasty, sports medicine, rehab, and radiology. Because it's multidisciplinary nature, we're able to refer to each physician's expertise and have a team approach to patient care. We meet weekly to discuss complex patients and come up with the treatment recommendations and have multiple experts review each patient, which benefits the patient and their care. Today, we're joined by three of those experts, Dr. Peter Moley, who's a physiatrist on the hip preservation and sports medicine service. He specializes in the treatment of hip and lower back injuries. We have Dr. Anil Ranawat, is specialty trained in both sports medicine and hip preservation. He presently is the chief of the hip and knee division of the Sports Medicine Institute. He is also the assistant team physician for the New York Mets and Rangers. We also have Dr. Danyal Nawabi, who's an orthopedic surgeon on the sports medicine and hip preservation services. He's an expert in hip arthroscopy and performs approximately 200 of these every year. He's involved in the care of professional soccer players and therefore has a unique experience in treating hip problems in athletes. He also performs hip resurfacings and replacements in young active individuals with arthritis and dysplasia. The topic of labral tears is important, as many patients are referred to us or come to us with a diagnosis of a labral tear on MRI. And the treatment of this is a lot more complex than just repairing or fixing the labrum. So our first question, I'll ask Dr. Ranawat, what is the labrum and what is its function?
Well, the labrum is a ringed shaped structure that lives on the cup of the hip joint. There's a femur, which is the bottom of the hip, and the cup is the top, or the acetabulum. And the labrum is a ring-like cartilage structure that maintains the stability of the hip joint. It also does a lot of other things in terms of maintaining a suction seal effect. It also maintains the cartilage homeostasis, or happiness, of the hip joint. So the labrum has key anatomical, physiological, and biomechanical functions, and it's quite important. So we learned about this by various scientific models, and also in our early experience when people remove the labrum completely, there's some deleterious effects of that. So through science, we've actually grown to appreciate and understand a lot about the labrum.
Dr. Nawabi, anything to add to that description?
Yeah, I agree with all of that. I think the thing to stress with respect to the labrum is that in its role as a pressure distributor and a joint stabilizer, it goes to the point that Dr. Ranawat just said, we as surgeons and doctors must be really careful to preserve that tissue, because any form of excision, removal, compromise of that tissue, because it's a shock absorber, if you remove it, your contact pressures in the joint will go up, which will result in rapid deterioration. And also as a stabilizer, if you remove it, you'll also get hip instability, whereby the hip then is predisposed to either in a severe form popping out of the joint or giving recurrent symptoms, muscle fatigue, overuse, trying to stabilize that hip. And as another point, I think it's important to mention that although the labrum has a good blood supply, it also has a nerve supply. So it's a pain generator within the hip. And so therefore part of the treatment sometimes, in addition to fixing the labrum, is also maybe to potentially consider denervating it to reduce it as a pain generator for patients.
Well, that's great. Dr. Moley, how do we diagnose a labral tear?
That's a good question. I think we go through this daily in our offices. And the first part of the diagnosis is that you have hip pain. So that would be the beginning of having a labral tear. From there, the actual visualize and see a labral tear will combine a physical exam, a history, and imaging. And an MRI is very important. It shows the tissues of the joint, and the labrum is tissue that can be seen using an MRI. MRIs come in different forms. We at HSS prefer what's called a non-contrast MRI. So an MRI can come where you go in and you go into the unit and you have your hip scanned, or you can go in, they inject a fluid into your joint, and your hip is scanned. When you inject a fluid, that's called a contrast MRI. The issue with an MRI is that we want it to be high resolution with thin cuts, so like an HD TV. And in the world of MRIs, you get a variety of a tube television to an HD television. And what people think they're all equal, and they're not. And so what you're looking for is to get high resolution with thin cuts, and in our world, without contrast. The reason to do that is that the MRI without contrast is very good at not only looking at the cartilage, and the cartilage is often a determining point in what your care is going to be, but it also shows the tissues around the joint a lot better as far as the ligaments, the muscles, the tendons, the health of the bone, reaction within the bone. So we can get a lot of information from an MRI more than just the labral tear. When you look at a tear, you have to be careful because there's a lot of terminology out there. It's torn, it's degenerative, it has a radial split, it's frayed, and those terms are thrown around. In the reality is that a lot of hips have injuries to the labrum, which are called a tear, but function perfectly normally. So if you take people off the street, put an MRI, you may see that there is an injury to the labrum. It's called a tear, a fissure, or split, but the hip is functioning just fine. So when you're looking to diagnose it, you want to have hip pain, you want to have a high resolution MRI, preferably without contrast, and then you're going to take that information and then apply it into an algorithm where you're looking at different morphology designs, which we're going to talk a little bit more.
So a follow-up, do you see patients with other problems that get an MRI and just have an incidental tear of the labrum?
I think that a lot of times that's the majority of my visits. The combination with the spine, the tissues around it, you oftentimes are going to see that was the diagnosis. I often say to my patients is, who made your diagnosis? And what happened is you had some pain. They were sent for an MRI. MRI had a labral tear, and they're told a labral tear, and now they're looking for different doctors. And the person who made the diagnosis was the radiologist. So it's very important to understand the function of the hip, the spine, the joint around there, the motion, and that's one of the nice things about the approach to these HSS. I work multidisciplinary. We're all in there together, trying to understand as best we can. So yes, oftentimes the reason for a discomfort is not the labrum, but it was found on the MRI. So it's very important to look at everything that goes around the hip.
Yeah, and they can't be with us on this webinar, but we do have a few radiologists we work with all the time, and we go over the images and the MRIs with them a lot. Dr. Nawabi, why does the labrum get injured?
Yeah, I think one of the analogies I'm going to start off with respect to that question is the other region in our body where we have a labrum is the shoulder. And so therefore, shoulder labrum tears in the shoulder joint itself, very commonly we associate those with a shoulder dislocation. Pretty much all of us will have heard of someone who's had their shoulder pop out. And when that happens, you tear your labrum. The hip is actually very different. And so usually the most common cause of a labral tear in the hip isn't that the hip pops out or a traumatic event. It's usually due to a nutritional problem, which means it's accumulated over time. And so the first thing to really clarify here is that a labral tear in the hip is usually a manifestation of some other underlying problem. It's not the problem in itself. And so with respect to the hip, usually this comes under the category of what is the bony deformity in that patient's hip. And so the two most common deformities that we as a group deal with is one category is hip impingement, and the other category is hip dysplasia. So hip impingement is the category that I see a majority of patients in with labral tears. And what does that actually mean? Impingement in orthopedics very simply means bony collision. So if you have a hip joint that's perfectly shaped with a perfectly spherical ball and a spherical socket, it's going to move smoothly. There's going to be no bony conflict. There's going to be no bony collision. In impingement, what happens is there's a shape mismatch. So usually there's an extra bump of bone on the femoral head side, or the head-neck junction is slightly misshapen. So it's almost like you got an egg-shaped head inside a perfectly spherical socket. And when that hip tries to move, it's not going to move smoothly. and that oval-shaped head is going to collide with the edge of the socket. What structure sits at the edge of the socket? It's the labrum, and so the labrum will get crushed. And through repetitive injury to that labrum over years, or in some cases, if you have a very active individual, a young athlete, who's subjecting their hip to high forces or extreme positions over a short period of time, that bony abnormality will result in a labral tear. So as I said, there's impingement and dysplasia, and not to say that traumatic episodes don't cause labral tears, but they're very much in the minority as opposed to the bony deformities. And in fact, at HSS in 2011, we published a paper where we found that 90% of patients with a labral tear, with a symptomatic labral tear, have some form of structural abnormality that would explain that tear. I think that's very important to understand before treating every labral tear as something that's significant and needs to be fixed.
Great. So what is more important to you, the status of the labrum or the status of the cartilage before you treat somebody?
Yeah, I think great question. And, following on from what Dr. Moley told us, in actual fact, for me, the most important thing is the status of the cartilage. So just to differentiate between those two structures, the labrum is a ring of cartilage that sits at the edge of the socket. It's a discrete structure. It's a shock absorber or the pressure distributor or the sealer, whereas the articular cartilage is a thin film of cartilage that actually lines the ball in the socket. And so the status of that is really important because the outcomes of all the surgeries that we do as hip preservation surgeons is very much dependent on the status of that cartilage. So to give you an example, if we take a patient with arthritis, who by definition will have worn out a lot of that articular cartilage, and if that patient comes to see me with an MRI that has a labral tear, they haven't had any x-rays done, it's quite likely that their primary pathology and source of pain is their arthritis and not their labral tear. So focusing on the labral tear in that sort of patient is going to be a mistake. Doing surgery on that sort of patient with arthritis who has a labral tear is not going to result in a good outcome. They need a different treatment, maybe a joint replacement. And we've learned also that the outcomes of our surgical techniques to repair labrums are very sensitive to even a small amount of cartilage damage. So for me, cartilage status is extremely important and should be evaluated with even more scrutiny than the status of the labrum when evaluating an MRI.
Yeah, as you had mentioned, one of the causes of labral injury is dysplasia that I see a lot of. And the labrum is, again, as you mentioned, just one of the areas that gets strained when there's not enough socket to cover a hip. And it certainly probably plays a small role in the long-term outcome of the hip compared to treating the dysplasia, because that has an effect on the cartilage. Which goes to the next question for Dr. Ranawat. Does the labrum have to be fixed in every case?
I think this goes back to what Dr. Moley was saying, is that too many people feel that their diagnosis is a labral tear because they were told on an MRI. And a thorough history and physical exam that Peter was talking about is really the key to figure out, is that imaging finding the true cause of the pain? And then to go to what Dr. Nawabi and yourself were saying, well, if the imaging finding is a true cause of pain, something inside the joint, what are then the characteristics of that joint? Is it a stiff impinging joint, or is it an unstable dysplastic joint? And when you get to all those variables and kind of reduce that number down, it's a small percentage of people who think they have an MRI finding of a labral tear that actually needs a procedure. And then you have to pick the correct procedure. So I'd say the most important thing is having a thorough history and physical, have a thorough understanding of the correct morphological or biomechanical environment of the hip joint, the bony problem, and then really confirm that all those are concordant. Then I think fixing the labrum is appropriate. But which also means the converse is that there are plenty of people that are convinced their labrum is the problem. And as Dr. Moley said, it's their back, it's something outside of their joint, it's a completely different problem. And I think we see this a lot, but the advantage of our team here, our team approach, is that we kind of put all of our heads together and really figure out what's really the primary problem here. And as you pointed out, Dr. Sink, that the labrum sometimes can just be the tip of the iceberg. There's many other factors that have to be considered and having a lot of different approaches and opinions, we really try to come to the best answer for the patient.
Yeah, and I can say for example, in hip dysplasia, when we do a periacetabular osteotomy, there's still a debate. Does the labrum need to be reattached or repaired at the time of the procedure? And in some patients, I'm glad we were there and you repaired the labrum, you and Dr. Nawabi, when I did the PAO. And then in some, we find we probably could have just done the PAO. And we're studying that further to decide which patients would benefit from that. And it doesn't affect the surgery at all, but I still think as you mentioned, addressing the impingement or the dysplasia, what's most important. Dr. Moley, can a patient with a labral tear be treated without any surgery altogether?
That's a good question, and it's been pretty well set up by Dr. Nawabi and Dr. Sink. When you're looking at labral tears, and the number is probably about 85% of the population, up to 85% of the population has a labral tear. Now we know 85% of the population does not need surgery. So the vast majority of people are going to sit in the middle between what we've been speaking about. You have your one side of the bell curve is going to be dysplasia or an undercovered joint, so a more under-constrained joint. And the other side is going to be this stiff joint that Dr. Ranawat was talking about, where it's over-constrained, and Dr. Nawabi was mentioning the design, the bony design doesn't fit well, and the labrum takes stress over time. So I've got two sides here, but in the middle is the bigger part of the bell curve. And a lot of those patients are the ones who are going to do very well without any type of surgery and being treated with advances we've done in physical therapy, understanding of mechanics of the joints. You still have to understand the morphology, or morphology really being the design, how that ball and socket come together, and then apply that into certain activities. Are you doing lunges? Are you doing CrossFit? Are you putting too much stress on a joint? Coming back to what Dr. Nawabi was talking about with the cartilage, it's very important. So a lot of what you're going to see is someone has some cartilage damage. Now we know that doesn't do well with arthroscopic surgery, but it actually might do very well for a long period of time with some modifications in activity, some strengthening, and putting that together with physical therapy. Occasionally you'll add an injection or something to this. But basically the majority of people with labral tears are going to get away without any surgery. And what we have to understand then is, if someone comes in, my job is to give them a pathway, which may not include surgery, but then to be reevaluated on intervals to where maybe at first I thought one thing, but another time that seems to have changed. You know, it's a lot of data is coming in and we're trying to come up with one conclusion, but we reevaluate and we keep checking. And then there's that complex patient we're not sure about, and then we discuss it. So we get together each week and as a group and go through these harder to understand patients. So there's a lot of patients that are cut and dry. They don't need surgery on either side, and they can be fine. There's some need surgery, and I have to understand that as well as everybody else, and on each side of the curve. And then there's the gray area where it seems like we might be able to go without surgery, but our job is to always reevaluate, get together, speak about it, get the group in and say, what's the best pathway for that patient? And I think that's oftentimes what gets missed in the non-operative care world, is that I see a patient who's been given all the injections and then therapy, and then seen all these people, when you realize that they were on the side of the curve. They needed a PAO or a procedure to increase coverage, or they needed a arthroscopic surgery, but they weren't offered that because the team wasn't there. It was one practice doing what that one practice does. A nice feature to understand who does well and who doesn't do well is to know to understand where the boundaries are. And that's, I think, what we've tried to achieve, and I think we do achieve very well within the hip preservation group.
Yeah, you bring up a point. Sometimes the diagnosis isn't so clear of what's causing the pain, and there's multiple factors. And having the three of you is very helpful, that we have this conference and we're able to bounce things off of each other to try to find really what the best treatment or non-operative treatment is. And so Dr. Ranawat, when somebody has, let's say, a mild impingement or dysplasia and they get better with treatment, how do you monitor them just to make sure? Do you repeat MRIs? Do you see them back just to make sure that their hip doesn't get away from them?
Yeah, I think monitoring both the non-operative and the operative patient needs a thorough follow-up. Your history and your clinical exam is always your workhorse, and that's always where you start. If it's been a longer term follow-up, sometimes we get radiographs. X-rays are very helpful to look at the health of the joint, as Dr. Nawabi was saying, the cartilage status. It's a traditional way to evaluate them, but it still has a tremendous role. And there are times where we get MRIs too, to follow long-term patients for more subtle features. But to routinely get an MRI post-operatively or non-operatively is not indicated, and it's not an appropriate use of healthcare resources. But there are always small times where it is indicated.
Well, thank you. And our sort of final question that I'm sure all our patients ask us, Dr. Nawabi, is how successful is surgery for patients with a labral tear?
I think the short answer to that question, number one, is it successful or not? The answer is yes, it is. And so I'm going to talk with respect to arthroscopic surgery then for labral tears and impingement. What we've learned is that the success in terms of, if you look at patient-reported outcomes, that's a metric that we tend to use now, with our patients telling us how happy they are. Approximately 90, that improvement on a scale is about 90%. So patients feel almost 90% better from where they were pre-op to post-op. And what we've learned is that there are some factors that dictate whether you're going to be close to that 90% or maybe not so close. And one of them is actually age. So if you take a patient who you worked up, looked at their bony morphology, identified them as an ideal candidate, and they're below the age of 30, those patients, you can quite reliably predict that they're going to be in that 90% category. And then what we've learned is if you take a patient on the other end of the spectrum and even go over the age of 45, that success rate drops. And that's something we're studying, but there are multiple factors that come into it, maybe hip health, cartilage, etc. But age has definitely been identified as a predictor, as has sex. And the other category we treat are athletes. And return to sport is a big criteria as well for high school, collegiate athletes. If you do this surgery on me, doctor, am I going to play my sport again? And again, in a young athletic patient, the return to sport rate is as high as 90%. And getting back to sport at 90% rate actually within 6 months. So I think those are some of the metrics. Finally, in success, we also talk about failures, or what's your failure rate? That's the other way to define it. And if you, again, using modern arthroscopic techniques, because it's an evolving field, the techniques we're using in the current day and age or developed within the past few years, the failure rate's actually as low as 2%, with the failure being a patient needing another surgery or not achieving the outcomes they expected or needing a hip replacement, for example, or another hip arthroscopy. So, we're looking at success rates in the 90% range and failure rates as low as 2%. So the answer to your question is very successful, thankfully.
Good. Dr. Ranawat, do you have anything to add to that?
No, I think Dr. Nawabi was very clear. I mean, I think the key is picking the right patient. And not every labral tear does well with surgery. To go back to Dr. Moley's point, is that because they probably didn't need to have surgery. But if you pick the right patient on history, clinical, physical exam, imaging, and you have a multidisciplinary approach, then they will do very well, as Dr. Nawabi pointed out.
Yeah, that's correct. It's the same thing with dysplasia is, treating the cause of the labral tear, similar outcomes with the PAO as to hip arthroscopy, and age and other factors come into play to affect the outcomes. Well, that was, I hope, helpful for patients to understand a labral tear. We do know that the tears are very common, as Dr. Moley mentioned. MRI, the word tear is what's used, but there can be multiple different things going on with the labrum, and tear is the commonly used term. It may not be even the labrum or the hip that's the issue. what cares about, as was mentioned, is the diagnosis of why the labrum is irritated and why the hip hurts, and that often has to do with a bony issue, or it could be something that could be better with rehab. The labrum doesn't always have to be repaired. What's primary important is to repair what causes the labral irritation, either through extensive non-operative methods, which we would prefer if possible, or if they have surgery, to do the correct surgery safely. And again, we use each other daily as sort of second opinion. So every patient that comes in should feel like they are part of a system that really cares about treating what's best for them. And we all get together at least once a week to discuss complex hips to help us have the right diagnosis and the right treatment for people. Any other closing comments before we sign off? Well, that was great, guys. Thank you very much.
Thank you, Dr. Sink.
Thank you, Dr. Sink. That was great.
Sink.